आयशा इज फ्रॉम कराची, वहाँ पे कंसल्टेंट हैं. शी इज गोइंग टू टॉक अबाउट कॉन्जेनिटल नेजल लैक्रिमल डक्ट ब्लॉकेज. हाँ हाँ बैठ जाए, बैठ कोई हर्ज नहीं. कॉन्जेनिटल नेजल लैक्रिमल डक्ट ब्लॉकेज.
Assalamu alaikum everyone. Okay, so nasal lacrimal duct obstruction is common in the pediatric population and presents as persistent epiphora, recurrent conjunctivitis, crusting, occasional dactylocystitis, and regurgitation test may or may not be positive. So quickly going through the pathophysio: blocked duct, backflow, stagnation of bacteria, and periocular crusting and discharge. This dactylocystitis is typically low grade, and organisms are usually the normal flora. What is the differential diagnosis for epiphora then? NLDO is by far the most common cause: glaucoma, corneal irritation, and conjunctivitis. The level of obstruction could be pre or post sacral. These could be the different causes: nasal lacrimal duct, punctal agenesis, congenital fistula, craniofacial defects. Persistence of membrane at the valve of Hassner in the distal lacrimal duct, post-traumatic obstruction, acquired causes of NLDO, and incidence of is higher in children with craniofacial abnormalities. These could all be the causes of NLDOs. So 2 to 4% of patients of full-term infants are born with NLDO. Onset of sign within the first month is around 80 to 90%, and spontaneous resolution is in far the majority within first year of life. The management is initially is conservative with non-surgical treatment. Spontaneous improvement is expected in majority of the cases, but if it's a significant epiphora, then digital massage is done. But please do demonstrate how the proper technique is involved in it. Treatment with topical antibiotics if there is significant discharge. It is not necessary to stroke the finger in a downward motion over the lacrimal compression. Only the lacrimal compression of the lacrimal sac is more than enough. The caregivers must be counseled that the benefits of topical antibiotics are usually temporary, because people sometimes think that when you're giving drops, this will resolve all the problems. So that is not the case. It is just a temporizing method, just so that the infection is not there. So this demonstrates a child who is being massaged just by giving a little compression on the nasal lacrimal sac. The objective of NLD probing is to establish a connection between the NLD and the nares by removing the obstruction at the distal duct. Some important pearls: nasal decongestion is important. Packing can be done either endotracheal or throat pack. Puncta should first be identified. We should know that before you go ahead, of course, the puncta is important to know that they're not arteries or anything else. Ensure that the probe is in the nose. This can only be, told by if there's a direct visualization of the probe that you've inserted, or there's metal-to-metal touch. Other than that, fluorescein, pyridine, or methylene blue can also be given during the syringing process to retrieve it in the on the pack. So probing is done first in a vertical direction. You move the punctal dilator just to dilate the puncta. And then a probe is used first in a vertical direction like that, and then horizontally till you feel the heart stop. I don't know if you can figure it out, but I did feel a heart stop there. And it is repeated force for the lower, the inferior punctum as well as the superior punctum, and to feel that the patency of the canaliculus is there. Once you do that, the probe is then turned approximately 90 degrees and passed into the distal duct through the obstruction into the nares, like this. Complications of delayed treatment: of course, there's continuous epiphora, recurrent acute bacterial conjunctivitis, families, of course, very distressed, acute dactylocystitis or orbital cellulitis. The surgical rate, the success rate for nasal NLD probing is 75 to 90%. Some surgeons simply repeat probing as a first choice. Other options, of course, they are the stents, balloon catheter dilation, turbinate and fracture. And of course, rhinocystotomy, either external or, or an endoscope, but of course when a child is a little older. Next, we come on to this other entity, which is the congenital dacryoceal, which accounts approximately for 3% of NLDOs in neonates and infants. Lacrimal sac is distended and a visible blue mass in the skin overlying the lacrimal sac can be seen. Almost all are associated with cystic lesion inside the nares. Kink of the common canaliculus is there, and the blockage is at the valva rosamala. It is present below the medial canthus. The fluid within it is mostly the amniotic fluid. So the dacryocystoceles are clinically important for two reasons. If large, they may cause respiratory problems in newborns, which may be range from acute respiratory distress to intermittent feeding difficulties. Also, an acute lacrimal sac abscess may result in serious problems because of the weak immune system, and so prompt treatment is essential if you encounter an abscess. If it is not infected, you do warm compresses, topical antibiotics, and a digital pressure may be applied. But if it is acutely infected, systemic antibiotics, NLD probing with a success rate of 75%. NLD cysts are almost universally present, so do examine the nose with the nasal speculum or an endoscope. Lacrimal probing and endoscopic removal of this cyst is curative in more than 95% of the patients. Thank you.
Thank you very much. Next speaker is Mr. G. Is going to discuss about management of congenital with viscoelastic.
Assalamu alaikum. So probing with viscoelastic and the aim of the lecture is that audience will be able to know a new step in probing. As Dr. Aisha has very well explained about congenital epiphora and congenital nasolacrimal block, the most common presentation of children with epiphora is due to congenital NLD block, and they present like this. And when we examine these babies, they had sticky lashes, red eyes, yellowish discharge, and parents give history of watering and discharge since birth, and they are also in distress. So we diagnose them as a cases of congenital NLD patients. So as we know, the treatment options, we have got lacrimal massage, probing, close intubation, DCR according to the age of the patient. So today we would discuss the probing. So you have to give general anesthesia, and then you have to dilate the puncta, pass the lacrimal probes, and perforate the valve of Hasner. So that's the traditional method. But sometimes we get bleedings, fistula, tract formation, mucosal injury, because we put the metallic probe into the. So what I do, I use this viscoelastic in a syringe after dilating the puncta, and it lubricates the mucosal passages more. And then when we put the lacrimal probe, it goes smoothly. It doesn't cause false tract formations. It doesn't cause much epithelial erosions, bleeding. So it's a little bit innovation. We put this viscoelastic and we get very good results. So here you can see first step is punctum dilation. And now this viscoelastic, which we use commonly for intraocular procedures. So now we have also tried for extraocular procedures. Now putting the viscoelastic. You can see this gel. And now with the lacrimal probe, first vertical, then horizontal, and then again vertical. Now it goes very smoothly. It doesn't injure any internal passages, lacrimal passages, and then we perforate. So I highly recommend this one-step addition in conventional therapeutic technique to further decrease the chances of complications and increase the success of the procedure. And it is not limited to pediatric age group. It can be used in adults. You can use it in adults before insertion of silicone tube. You can use it in canalicular stenosis cases, in closed intubations, in therapeutic probing sometimes is done in adults. So we can also use, we add this a small step. And I have also done a study on it, comparison of therapeutic probing with and without viscoelastic for congenital NLD block. So people can also study it. Thank you.
While Professor Saab is in process of connecting, I would just like to make comments regarding the two presentations, Jaljeed and Aisha. That although it is just the probing which does the work, but you know, for our heart and to confirm and to sometimes show to the family that it has gone through. We stain it with the pyodine, but sometimes we are doing both. So a little change which we do, on one side we use pyodine and other side methylene blue. So because when the throat pack is removed, it is very colorful and the parents are very happy.
ये दो तीन कमेंट्स से. Would you do probing with a blunt probe or with a sharp probe? आप किससे करते हैं?
So, prefer with a blunt.
ब्लंट से करते हैं, शार्प से नहीं. एक वो नॉब आती होती थी प्रोब.
Yes, olive tip.
हाँ जी जी. दूसरी बात, ये जो मसाज है ये कहाँ पे करते हैं? हैं कहाँ पे? किस चीज़ को मसाज कर रहे हैं? हैं सैक को कर रहे हैं, डक्ट को तो नहीं कर रहे. तो नहीं कर रहे. हाँ, वो इट्स वेरी इंटरेस्टिंग. जो मैं बार बार देखता हूँ ना, पेशेंट आते हैं, हमने बड़ा मसाज किया. कैसे किया? ऐसा आई डोंट नो व्हाट इट इज. हैं मैं ये मैं उनको कहता हूँ कि इससे बेहतर था कि अपना कर लेते. उसको ऐसे तंग करते रहे बच्चे को.
सुंदर.
यू हैव टू प्रेस द सैक्स. सैक अंदर होता है. सो मैं हमेशा compression.
Yes.
It's not massage. No. And they are told to do it, and they are told to do it 20 to 30 times each, 5 or 10 times a day, 20 to 30 press. एक दफा करना काफी है. Press is firmly, बस. The purpose is just to create a pressure, and if there is a thin membrane that gives way, that's the only reason. And it does not give way, fine, it is not going to work. Then we have to tell the patient that this duct is in the process of growth. Why are we not probing it now? Just because we expect it to open and grow by itself. And when we see that it does not, around the age of 9 months or 1 year, then we go for it. So many is you have to tell them and convince them. Otherwise, they are in the process. Ki, kuch karo, do something about it. Then why don't we do probing in adults? Why only in the children? Kyun ji? Don't do nasolacrimal drug probing in the adults. Why?
Yes,
why?
sir.
Why not?
Sir, because in children that is a very small area and it's easier to manipulate, and in the adults it's more curved
लंबा
and
होता है
wavy.
रास्ता.
बड़ा होता है, wavy होता है, and it's like if you
You said it's sinuous. The nasolacrimal duct in adults is not straight.
yes.
बच्चों में straight होती है. So just go along and it's easy to do. So what's the purpose of probing? Why do we do probing?
सर फॉर्निक्स रह जाएगा हमारा.
हमें हो जाता वो हमारा टाइम है चलो छोड़ो.
जी सर.
So we fornix formation. ये चलेगा भाई? उल्टा पकड़ा हुआ है, सीधा कर. So the normally used procedure. I just wanted to tell some small innovations in the formation of fornix. You start मैंने की थी, then other people adopted them. That's good. So there's a normal procedure used for fornix formation. इसको फिर सीधा कर दिया. So you incise the conjunctiva. That's a contracted fornix. We deepen the fornix. इसको हम deep ले जाते हैं, right? So this area is epithelialized and this is not epithelialized. So we have to just expand it as much as you can. So that's the expansion of it. Then you take the mucosa from the lips, cheek, or anywhere you feel like, you harvest it, and then we apply it into the fornix. We cover the raw area with the mucosa, and then we stitch the edges of the graft to the raw edges of the raw area, or the mucosal margins. So this is, and then we deepen the fornix with the rubber tubing, straight to the periorbital, so that it keeps the fornix deep. Other ways, we just insert a conformer of a good size, and that keeps the mucosa into the fornix and keeps it patent. So that's a way of doing it. Normally, we do like that. And then we insert a conformer, and that's taken out. So this is a cumbersome procedure, a long one. Then I devised a method of doing a 360-degree fornix formation with a super glue technique. We devised it many years ago. I just wanted to present today. So creation of appropriate space and lining of mucosa, time-consuming procedure. You have to go through it. You have to open the fornixes all around. You have to go through the procedure 4 times. So the other way, alternate, was to wrap the conformer with the mucosa and just insert it there. ठीक है ना जी? And we use a commercially available super glue to attach the mucosa onto the conformer. The epithelial side is on the outer side, is towards the conformer, and the other side is towards the raw area. You will see how we do it. So that is it. That's the space we have. That's the space we have created. That's the space we have created. We stop the bleeding. That's the area to be. The mucosa has to be. We harvest the mucosa. And super glue is applied stage-wise. I will show you how. There is a mucosa. We apply it bit by bit and just start wrapping. And we go all around. You see, We are covering the whole of the conformer, and there is the conformer covered with the mucosa. Epithelial side on the conformer side. Epithelium is on the conformer side. And we just simply, this is the conformer and this is our lateral profile, and otherwise it's covered by the, and then just insert the conformer with the mucosa on it into the space available. So temporary tarsorrhaphy is done, is removed after a week. Now the conformer is attached to the mucosa, but as the epithelium grows, after a week you are able to separate them very easily. And that's the conformer which has come out. And this is the lining. Oh. ये ज़्यादा आ गई हैं. Sorry. And that is the artificial eye in place. The other method is I use an amniotic membrane in place of the mucosa. Again, we create a space, and that's the amniotic membrane, keeping the epithelial side towards the conformer. But I don't wrap the conformer in this case. I use a very simple technique, and everybody can use it. So easy. You see, we have opened the eyelids, retracted the eyelids, and I just put the amniotic membrane on top of it, and then top of the eyelids, and then I open the eyelids. So the amniotic membrane is right under the retractors. So, and then simply put a conformer on top of it, push it in, and pops in. There it goes in, taking the amniotic membrane along. You don't have to line it. It is automatically lined. So there it is, and we trim the extra amniotic membrane. We simply trim the extra amniotic membrane and just close the eyelids. And the conformer by itself wraps the amniotic membrane around. You need not do anything, no stitching, no placement, nothing. And so just a 5 minutes procedure, just putting in the conformer, pushing it in, and it takes the shape by itself, the amniotic membrane. So when you take it out, you see it's all lined by the amniotic membrane, and you can see the fornix has been formed. Now in these cases, well, the problem is that amniotic membrane is not a substitute for mucosa. It's not going to keep the fornix open as long permanently, but at least the space is created. We do it in hopeless cases. A space is created, and when need arise, you can put in extra grafts whenever needed. But at least space is created. So very easy method, and so simple, and anybody can do it. All you need is an amniotic membrane. See, the fornix formed. Thank you for your attention. Thank you.
Thank you so much, sir. That was really innovative and really updated us on what to do next time in a simpler manner. And I would now like to ask Dr. Zahid to come forward, please, and tell us about the alternative methods for Lester-Jones intubation.
Bismillah ar-Rahman ar-Rahim. As we all know, when the proximal canalicular system is not intact, the next hope is to do a DCR and insert a tube, Lester-Jones tube. But as we have got different challenges, it's not sometimes available, and the issue of cost. So that made me think about these alternative plans. This is introduction of the Lester-Jones tube. This is what it looks like for the trainees. And there are innovations like it's a frosted, it can be frosted, and now they have put a flange on it so that the extrusions become less. But there are still the chances of it becoming extruded out of the system, and it may be broken sometime. So these are the indications. It is also very important to measure from midline to the canalicular, to the medial canthus distance before you order a tube. We have also devised a technique where we get some, the industrial thing, and we can reduce this size on the table in the operation room. So as working with Professor Sahab, he always gives us new ideas and pushes us for alternate techniques. So we use this 10 cc syringe needle to make a new path where there is no proximal path, and then to cannulate. Please play करेंगे. So you can see this is the needle which comes with the disposable 10 cc syringe. So we make a new path and then insert a bicanalular tube. And you can then top it up with the transcanalicular endoscopic technique or an external technique, whatever you prefer. Next slide, please. So the tube is retained, and you may like to keep it for a longer period, maybe 4 months. And another way is for these cases and other dactylocyst or anastomy cases, that we mobilize this tube every 2 weeks. So it's very simple, can be done in outpatients. So with the Murphy forceps, we hold the tube here, and with the artery forceps in the nose, and just little bit of movement that will break the adhesions. These are the references. Thank you very much.
Thank you so much, Dr. Zahid. Indeed, a very nice method that we can apply. So now I would like Dr. Ramsha Jahangir to come and tell us about post-traumatic cicatricial ectropion correction with skin grafting.
Assalamu alaikum. Today my topic of presentation is post-traumatic cicatricial ectropion and its correction with skin graft. My patient, 4 years old male, presented to us in eye emergency with history of RTA at night with broken windshield of a car. It was a right upper lid crush injury with intact globe. There was no past ocular history. On general physical examination, the patient was conscious, alert, and crying in pain. We looked for any other injuries or fractures too. Most of the examination was done in GA because the patient was in agony and pain. On examination, I found right upper lid crushed injury, full thickness laceration around 3 centimeter involving the lid margin with large tissue defect and small bony fractures of superior orbital rim. Amazingly, the globe was intact and the cornea and sclera was intact. Fundus was within normal limits. Patient was vitally stable. On digital X-ray, we can see here the superior orbital rim fracture with bony fragments. We managed the patient as an emergency. After giving him painkillers, IV fluids, we confirmed the NPO time and repair was done. I did the primary repair on the GA by cleaning the wound with pyridine solution, removing the foreign bodies, identifying the structures. As we can see, the levator palpebral superioris and orbicularis oculi was majorly injured. So I did muscle to muscle repair, then skin to skin repair, probing and syringing was done, and it was patent. These are the blood-stained glass particles found from the wound. This is the picture after primary repair, as we can differentiate between the two pictures. It was not an easy surgery. It took like 2 to 3 hours, but totally worth it. This is 1 week follow-up. The vision was 6 by 6. We can see the healthy granulation tissue, and the healing process is going on. After follow-up of 3 months, the patient was happy, but the story doesn't end here. The patient's mother complained that the patient was unable to close eye due to ongoing scarring process. But as we can see here, both eyes have poor Bell's phenomena. So, sorry. As we can see, there is poor Bell's phenomena. So we quickly go to the surgical option. I diagnosed it as post-traumatic upper lid cicatricial ectropion. Moving quickly through the grading system, we have 4 grades for grading the cicatricial ectropion. In grade 1 and grade 2, there is punctal eversion and whole length posterior margin not opposed to the globe. In grade 3, palpebral conjunctiva visible, and in grade 4, fornix is visible. I diagnosed it as grade 3 cicatricial ectropion. As we can see, the palpebral conjunctiva visible. We counseled the parents, consent was taken, the lubricants was added, and we planned for the surgery for post-auricular full thickness skin graft repair after releasing scar. In this video, first we incise the skin 3 mm away from the lid margin. Then we released the scar by blunt dissection, and we measured the wound gap and multiplied the reading 1.3 times to avoid the primary contracture complication. As we can see how neatly it is done along the lid crease. The wound gap is then measured horizontally and vertically by vernier caliper. We took it on a stencil and take the post-auricular skin graft. We placed the graft over the wound and stitched it with interrupted Vicryl 6.0 sutures. This is the best example for imbibition phase that occurs within the first 48 hours, in which the graft changes its color from white to blotchy blue and healthy pink. After 1 week, we can see the uptake of the graft with pink healthy color. This phase is called inosculation phase that goes along after 48 hours. This is a 1 month post-op result. We can differentiate between how the patient came to us, and the take-home message is lid laceration management does not end with the primary repair, as the scarring is an ongoing procedure. So it should be kept on follow-up to spot the cicatricial sequel. And post-auricular grafts provide best cosmetic and reconstructive results. And due to high vascularity in children, the graft uptake has better results. These are some references. In the end, I would like to thank my Mayo Hospital team, especially Dr. Zahid Kamal, Professor Intizar Hussain, my supervisor, Dr. Ali Ayaz, and Dr. Salman Hamza. Thank you.
Thank you, Dr. Ramshad. That was a very nice presentation, very meticulously done by you. Now I would like to ask Dr. Hafiza Sadia Imtiaz, very nice and upcoming fellow at the Mayo Hospital. And she will be presenting on anterior lamellar repositioning with blepharoplasty for upper lid entropion.
Assalamualaikum. I am Dr. Sadia, Fellow of Orbit and Oculoplasty at Mayo Hospital, Lahore. I will be discussing anterior lamellar repositioning with blepharoplasty in entropion. So what's the entropion? Is a malposition that results in inversion of eyelid margin. And we broadly classify it as involutional entropion, cicatricial entropion, spastic, and congenital entropion. What are the morbidities which are associated with entropion? It leads to ocular surface irritation, ulceration, and then ultimately loss of vision. So the successful management is important because it leads to cosmetic results and rehabilitation of the vision as well. But for this, appropriate classification and management choice is very important. I will be discussing the eyelid cicatricial entropion of upper eyelid. It is very challenging condition to manage because it represents the continuum of progressive as well as non-progressive cicatricial disease. We classified the entropion into three categories as mild, moderate, and severe. Mild is when the posterior migration of meibomian gland orifices and the lashes are touching the globe only on up gaze, and it can be managed with anterior lamellar repositioning. Moderate, the above criteria, as well as when the lash touching the globe even in the primary position, and there is tarsal thickening as well. It can be managed with anterior lamellar repositioning along with lid slit. Severe when the disorganized margins are also associated with trichiasis, dystrichiasis, and the lid retraction, and it can be managed with the tarsoconjunctival rotation and the posterior lamellar graft. Common surgical procedures which are performed for upper lid cicatricial entropion are the anterior lamellar repositioning and the terminal tarsal rotation. Two studies were conducted in the UK and Australia, and they compared these two procedures over 7 years period in 52 eyes, and they conclude that upper eyelid cicatricial entropion can be effectively managed with anterior lamellar repositioning. So this is the way for diagrammatic representation of anterior lamellar repositioning and the lid slit. So a quasi-experimental study was conducted at eye department of Mayo Hospital. It's actually an ongoing study, and the inclusion criteria was upper eyelid cicatricial entropion of mild, moderate, or severe, and the procedure was anterior lamellar repositioning with and without blepharoplasty. And our outcome variables that were set are the anatomical success when the lid margin is restored to its normal position, and the complete success was defined with no eyelashes touching the globe. So the procedure involved first is the local anesthesia was given, and the incision made 4 mm above the lid margin using the scalpel 15 number blade. Blunt dissection of the palpebral portion of orbicularis oculi was done. Gray line incised along the full width with posterior to the meibomian gland orifices. Anterior lamella repositioned superiorly and sutured to the anterior tarsal plate using vicryl double arm 3 or 4 interrupted sutures. With 3 or 4 double arm interrupted vicryl sutures, strip of the skin and orbicularis excised, and the closure of the incision was done with interrupted vicryl 60 sutures. So the first was to identify the meibomian gland orifices. Now, these are turned inside, skin incision made 4 mm above the lid margin. Then after blunt dissection, gray line is incised along the full width of the lid. And it is very important to hold the proximal end of the tarsus with the that is artery forceps. And care should be taken not to damage the levator aponeurosis, otherwise this patient will develop ptosis. Double arm vicryl 60 sutures applied. And it is very important to turn the artery forceps to confirm that the stitch is not full thickness. Now excise the excess skin and the orbicularis. Skin incision then closed with interrupted sutures. This is the pre-op and the post-op pictures. That's it. Thank you so much.
इसकी पिछली पिक्चर करेंगे अब आखिरी जो है
सर मुझे गलती पता चल गई है जो आप निकालने लगे.
चलो इससे पहले वाली जो डायग्राम दी थी आपने ये वाली
This one.
अच्छा ये समझाओ ना डायग्राम से सबको समझाओ क्या किया तुमने पॉइंटर लेके ना वो बड़े वाला इससे पता चलेगा सारों को आपने क्या किया ना. एंटीरियर लमेला क्या होती है पोस्टीरियर क्या होती है मुझे क्या
Anterior lamella contains the skin, a small amount of the subcutaneous tissue, and the orbicularis oculi muscle. And the posterior lamella contains the tarsal plate and the conjunctiva. So, yes, sir. This is the anterior lamella. This is the posterior lamella. This is at the gray line. Because this is the this is anatomical demarcation line between the anterior and the posterior lamella. Sorry. And then the posterior. So this is actually. So the separation was done at the level of the gray line. Yes, sir. Bleeding. Hemostasis. So first, so we have separated the anterior and the posterior lamella, and then is the anterior lamella is repositioned about bearing the 2 to 3 millimeters of the posterior lamella backward, while this is sutured to the tarsal plate using the vital suture double arm.
टार्सल प्लेट को आपने कुछ नहीं किया
No,
वो बताओ तो कुछ नहीं किया
no, the tarsal plate was not
इसका
excised.
फायदा क्या हुआ
So here we have not done any you can say the intervention with the tarsal plate, so there will be less loss of the meibomian orifice, meibomian glands. So we have just repositioned the anterior lamella that will contain the disorganized as well as the trichaetic lashes.
और इसको क्या तकलीफ थी
And so that will correct the anatomical position.
उधर दिखाओ क्या था
Yes,
क्या बात
posterior margin that is inward, and here it is.
वो दिखाओ ना डैश अंदर जा रही है
Yes,
Before and-
trichaetic
अब
lash,
इसको पुल आउट
and now
कर
it
दिया,
is
अब वो बाहर
out.
असल बात बताओ
चलो वेल डन.
ये शाबाश
जी उसको रीपोजिशनिंग रिसेस कर लेते.
हाँ जी आपको बेटे जो पॉइंट होता है ना मेन उसको हाईलाइट आगे दिखाओ
नेक्स्ट
Thank you, Sadia. I think. Thank you, Sadia. I think the next presentation is again by you as well, and you will be telling us about the lateral tarsal strip for involutional entropion. Yes.
So the next presentation is lateral tarsal strip for the lower lid entropion. So this is a very common entity that we encounter while working in our tertiary as well as tertiary teaching hospitals. So what is involutional entropion is because of loss of horizontal lid support with canthal tendon laxity due to dehiscence of the lower lid retractors, and also because of the overriding of preseptal or pretarsal orbicularis oculi. Its assessment can be done by snapback test, lid distraction test, and asking the patient to forcefully close the eyelids so you can see the overriding of pretarsal by preseptal part. One of my teachers says that involutional entropion means only the lower lid entropion. So the lateral tarsal strip, it involves the lateral canthotomy along with lateral cantholysis while transection of the only appropriate crus. Eyelid is then separated into anterior and posterior lamella at the lateral end, and the tarsal strip fashioned from the posterior lamella, which are then anchored to the lateral orbital rim. We know many indications of lateral tarsal strip. Mainly it's done in ectropion, that is senile or paralytic ectropion, recurrent ectropion, cicatricial one, congenital, when there is congenital malpositioning of the lower eyelid, also when the lower lid laxity following trauma or enucleation, and another important is the involutional entropion. So I studied this in patients with involutional entropion of the lower lid. Pre-op complete assessment was done regarding the overriding as well as the laxity, to check the laxity, and other complete ocular examination as well. Lateral tarsal strip was done with or without everting sutures depending upon the etiological component that was predominating. So first the local anesthesia was instilled at the lateral orbital margin. Lateral canthotomy was done. Following with cantholysis, and the blunt dissection was done to expose the lateral orbital rim. After this, the anterior posterior lamellar separation was done and the lateral tarsal strip was made. It's very important to actually excise the mucocutaneous part over the tarsal strip and also do the cautery over the conjunctiva. Here the cautery is done to the conjunctiva of the tarsal strip. And then double arm purline suture was passed from the upper and the lower end of the tarsal strip, and it is anchored to the lateral orbital margin. After this suture was buried deep, so the knots were not exposed and they will not cause any irritation. And the lateral canthal angle was formed to give the more sharp look to the lateral canthus. It's an option. Some do the lateral canthal angle formation, some don't. Excess part of the skin from the anterior lamella was then excised, and following the deep sutures, skin sutures were applied with Vicryl 60. So this is the case first here. Here the you can see the because of the laxity, the involutional entropion is very severe, and it was corrected with lateral tarsal strip along with everting suture was applied, because here both the laxity as well as the overriding was there. This is the second. Both eyes had involutional entropion, and it was also corrected with the lateral tarsal strip along with everting sutures. And here is another. It was here the laxity was predominating, so only the lateral strip was enough in this patient. And the take-home message is, while you can see this white reflex has the cataract, which we indulge to do the phaco in such patients, but before doing, you should look for the periocular tissue as well. So these can be corrected before doing the any ocular procedure. That's it. Thank you so much.
How does it work?
Because it causes the tightening of the tendon.
How does it work?
So it causes the tightening of the tightening mechanism, because of the tightening mechanism, and the second was overriding can be corrected with the everting suture. No, sir, that was corrected with the everting sutures I have mentioned here. Because the force is transmitted from the laxity is when this is loose and there is no force, and here you have transmitted the force towards the lateral orbital.
The black sea,
so because the normal position, normal anatomy has disturbed and it is not rotated.
Glow.
ढीली होगी तो मुड़ जाएगी, जब टाइट उसके साथ लगा दो तो मुड़ेगी। एकदम इसके ऊपर ढीली पड़ी हुई है, जल बॉबल आपने उसको टाइट कर दिया, वो फ्लैट है, वो चीज उसकी खत्म होगी, और दूसरा जो उसको मसल कर रहा था उसको भी आपने ठीक कर दिया।
थैंक यू।
आपका बेसिकली एक और मैसेज ये है कि आपने स्पीडी रेट्रो के लिए एंटीरियर लिमेलर डिसेक्शन एडवाइस करना है और लोअर के लिए फिर पैच।
जी
Yes.
जी and the beauty of this procedure is that you can tighten as much as it is needed, and it is done at the lateral canthus. So if you are doing an inverse house shape excision, full thickness, there is risk of notch. I actually published this data in Annals of King Edward Medical University. 50 cases, 25 in each group, and lateral tarsal strip procedure had better outcome. थैंक यू सादिया।
Thank you, sir.
सर नेक्स्ट आप ही का है, आपने कंक्लूजन करना है। इफ देर इज एनी क्वेश्चन और कोई है?
नहीं अब सब हो गए।
आई वुड रिक्वेस्ट प्रोफेसर इमरान साहब।
So presentations have concluded.
Professor Sahab, please make comment about this, and before sir makes comment. अच्छा, ठीक है, he is going to show another presentation, and but we must appreciate the generation of Professor Munirul Haq, Professor Sahab, and Professor Asad Aslam, who has taken the brunt of teasing, insult for the oculoplastic. At one stage, nobody wanted to discuss or watch what we do.
Yes.
But he took all that brunt, and now that's the result. Now all the second and third generation of oculoplastic surgeons are working, and I think I've taken feedback, and one of the best program in this ACO conference is the oculoplastic. Most of the sessions, they were very much populated compared to the other. Thank you, sir.
वो कॉन्फ्रेंस से पहले मैंने एक लिखा था, स्पीकर और स्पीकर वाला, हमें नहीं हुआ, बाकी सबको तकरीबन हुआ। ये पूछ रहे हैं क्या होता है ना, वो कॉन्फ्रेंस हो रही थी ना, तो स्पीकर बोल रहा था, तो आगे 6-7 लोग बैठे हुए थे, ये अपना मेथड बता रहा है जैसे मैं बताने लगा हूँ, तो वो बड़े बेचैन बैठे हुए सारे। तो ये कहता है कि लगता है कि आप मेरा मेथड आजमाने में ना बहुत दिलचस्पी, आपको बेचैन बैठे होंगे, फ़ौरन जाके आजमाएं। वो कहेंगे नहीं जी, हम तो स्पीकर हैं, आगे देर हो रही है। तो उनका ये बंदा क्यों बैठा हुआ है, ये मेरा मेथड चलाएगा। कहता जी मैं तो स्पीकर वाला हूँ, बाकी पीछे कोई नहीं। तो वो पूरी स्पीकर और स्पीकर वाले बैठे हुए, बाकी कोई नहीं। तो ऐसे हुआ इस कॉन्फ्रेंस में। तो अल्लाह का शुक्र है ओकुलोप्लास्टी में नहीं हुआ। कल हमारा वो स्क्विंट वाला था,
Yes.
उसमें हमें साथ वाले कमरे से फालतू कुर्सियाँ लानी पड़ी, और उसके बाद भी लोग खड़े थे। हाँ चलो, हाँ कल वो तकरीबन मोर देन 150 पीपल उस छोटे से हॉल में, शुक्र है अल्लाह का। अच्छा, ये मैं टेक्निक इसलिए बताना चाह रहा कि फॉर योर नए बच्चे बैठे हुए हैं, इनके इसलिए मैंने कहा कि इनके बेनिफिट के लिए ना, देखो हम जब ग्रोथ निकालते हैं, बड़ी ग्रोथ तो मैं आपको नहीं एडवाइस करूँगा, छोटी ग्रोथ में देखो कितनी सिंपल टेक्निक है, बट इसको मैंने चलाना है। एक पेशेंट मैंने आपको बताना कि छोटा सा बच्चा है, उसको लिम्बल ग्रोथ है एंड इज प्रोग्रेसिवली ग्रोइंग अराउंड द लिम्बस। आप देखेंगे अभी इसको, दैट्स थी भी वो मेलानोटिक, ठीक है ना, ये सारी ग्रोथ है। तो इसमें कुछ बड़ी सिंपल टेक्निक्स हैं। एक तो एक्सपोजर आप बेहतर कर लें लेकर कैंटोटमी के साथ, जितना एक्सपोजर अच्छा होगा उतना ठीक रहेगा। कल वो लड़ाई हो रही थी, वो कह रहे थे जी मिनिमल इंसियन, मैंने कहा बिग सर्जन बिग इंसियन। ये देखो कैंथोटमी हो गई, अब ये देखें ग्रोथ ज़्यादा क्लियर नज़र आनी शुरू होगी उसकी एक्सटेंट। सो व्हाट आई डू, ये ज़रा आपने बेटे देखना, रेसिंग ऑफ द लीजन विद सबकॉन्जंक्टिवल इंजेक्शन, और उसमें एड्रेनालिन जो डालनी है 1 in 50,000 है. एंड हाउ यू प्रिपेयर दैट 1 in 50,000, आप 5 ml लेते हैं लोकल एनेस्थीसिया, अब 0.1 ml एड्रेनालिन डालते हैं. 0.1 ml, 1 ml नहीं डाल देनी, खुदा का वास्ता है. हाँ, मैं भुगत चुका हूँ इसलिए कह रहा हूँ. ये देखें हम उसके अंदर Can you see it now? ये सारी की सारी लीन जो है वो रेज हो गई. ओके, आपको ये भी पता चल गया नीचे अटैच है. ऑल ऑफ द लीन इज रेज्ड अप. उसके बाद मैं क्या करता हूँ कि so that is the reason. Sorry, marking of the growth with cotton. हमारा कई दफा ख्याल होता है कि अराउंड द ग्रोथ कुछ सेल्स होंगे जो पेनिट्रेट करके और परमिएट करके दिल के टिश्यू में चले गए. सो दिस सर्व्स बोथ पर्पसेस. पहला क्या, इधर मैं इसके ऑल अराउंड पोट्री करता हूँ 3 to 5 मिलीमीटर. अरे दो पर्पस उससे होते हैं. एक तो एक वेस्कुलरिटी होता है, इसका जो ब्लड सप्लाई है या साइड से आ रही है या निम्बस से आ रही है. तो साइड वाली सारी ब्लड सप्लाई जो है वो ये देखिए, ये सारा मैंने इसको डिमार्केट कर दिया यहाँ से लेके. अब जब इसको यहाँ से काटेंगे तो नो ब्लीडिंग प्रैक्टिकली नो. और जितने सारे जो है भी तो वो भी मर जाएंगे बिकॉज ऑफ सो सेपरेशन ऑफ कनेक्टर ऑफ फ्रॉम द स्क्लेरा. अब इसको हम यहीं से उठाएंगे, जस्ट कीप यहाँ से लिफ्ट कर रहा हूँ मैं. ये सारा लिफ्ट कर दिया, ये देखिए यहाँ से सारा लिफ्ट कर दिया राइट अप टू द लिम्स. ये practically you see practically no good. क्योंकि कोई ब्लड वेसल यहीं से पेनिट्रेट नहीं करता, तो साइड से आ रही है लिम्बस से. सो सेपरेशन इज द लिम्बस. इसका मैं आज भी बता रहा था, नए बच्चे आ गए कि जितनी कॉन्जेक्टिवल ग्रोथ्स हैं ये बहुत कम फल थिकनेस पेनिट्रेट करती है. दिस पेनिट्रेट एट अ वेरी लेट स्टेज द शुगर, so they tend to stay outside, superficially. तो इसको अब हमने इसको काट दिया. लिम्बस इज वन प्लेस जहाँ पे वो लेकिन the cells can go in. तो लिम्बस के ऊपर फिर उसको ट्रिम कर देते हैं. अब लिम्बस एक, अब इसको नॉर्मली जैसे मेरी प्लीज थॉक प्लीज करते हैं, ये कहते हैं फेस को भी और लिम्बस को भी. प्रॉब्लम क्या है हमारा, आप मुझे बताएं हमारी कितनी किराए में तो -70 या -80 तक चलते हैं, तो 20 पे जाती है तो 20 पे जाती है.
अब तो VR वाले छोड़ते ही नहीं, किराया कहाँ मिलता है हमें.
किराए और कॉर्पोरेट सारी दुनिया में मैंने देखा है वे आर अनप्रेडिक्टेबल. पूरी दुनिया anyway. So what I do is I cauterize the bed and I cauterize the limbus. How वो मैं आपको बताऊंगा. And then covering of the barrier surrounding connective. इसको मैं connective cover करती हूँ. How I cauterize इसमें थोड़ी सी innovation है. We don't cauterize directly with the cautery. जब हम इसको कॉटराइज कर रहे होते हैं तो उसके साथ कॉटरी के टिप के ऊपर पानी फेंक रहे होते हैं, ड्रॉपिंग वाटर ऑल द टाइम. इसका फायदा ये होता है कि टेम्परेचर नेवर राइजेस अबव 100 डिग्री. दोस्तों नहीं हो जाता कुछ नहीं बेटे वो डायरेक्ट कॉटरी कर रहे हैं विदाउट वाटर. नेक्स्ट ये देखिए ड्रिपिंग वाटर ऑल द टाइम. इससे इसका टेम्परेचर बहुत ज्यादा राइज नहीं करता. एंड इट इज वेल नोन दैट द मैलिग्नेंट सेल्स दे टॉलरेट हीट लेस देन द नॉर्मल. बड़ी मिनिमल सी कॉटरी हो जाती है एंड देयर इज बैरियर. constant dripping हो रही है और जो marks लग रहे हैं बड़े superficial और minimal लग रहे हैं. So what I wanted to show you how I use the cautery for the base and cautery for the plus. So different method, direct cleaning. Cryo मैंने इनको बताया कि I don't use cryo because most are cryos are not reliable. They don't freeze at -70, -60. They are freezing at -20, -30. So the problem it won't work and we tend to have recurrences. So we have to adapt to our local system. We have to see what is useful for us, what is necessary for us. So I use a cautery with dripping water. And that puts a light, heat marks, and that works very well. And then I just cover up the you can see I have undermined the surrounding going tower and just pulled it over the. अगर बहुत ज़्यादा हो, you can leave the square up there. Base square will be covered on the ABC. Base square will be left covered with the. लेकिन don't cover with a graft or something else. In other words, you can be recurrence and let them be. And then you can always use the stems or whatever you create.
So please sum up this session. Give your final concluding remarks.
आप multiply कर दो. मैं भी sum up करूँ.
Sudhir.
You have been to Pakistan for the first time.
Yes, sir.
We have got quite a time. 5-5 तक time लगेगा 5-7 मिनट तो लेना.
जी.
You can take your experiences. How you felt around, how you felt over the people, over the hospitality or hostility, whatever you feel like.
Absolutely. That means I'll never end.
Please, go.
A few minutes, please.
What will be next?
Yeah, I think I already mentioned with the hospitality in Patna, but I just wanted to mention a few things at least. I'm sorry I walked in to try to sort out some issues. I don't know if there is a word here called jugaad.
Of course, there is. Jugaad.
Do you have it? So the theme of the next Oculoplastic session, whichever next National POA conference, should be Jugaad and Oculoplastics. Chairperson, Professor Saab. And no, seriously, I mean it. I mean, the Westerners call it innovations in oculoplastics, give fancy names or whatever it is. And I think what you have shown, we may or may not agree with everything which is talked about, but you have to come up with local solutions. You cannot put your hands up in the air and say, I can't do anything at all. And I think a lot of it is basically common sense. He was talking about beautiful, and I picked up that one point that you mentioned. Sorry, I just walked in. That the tumor cells require much lower temperature than normal tissues. Where else in ophthalmology and ophthalmic oncology do you see that? Can somebody say? Anybody? Who does retinoblastoma work?
Yes.
Anybody here? Do you do retinoblastoma? Who does retinoblastoma? Just put up your hand. You point somebody, sir, or somebody young. I know. Then why are they not putting up their hand? What consolidation treatments do we use in retinoblastoma intraocular treatment? Anybody? Just what is thermotherapy?
Basically, we're killing up the cells by using the coagulation technique with thermally we kind of kill the cells.
How?
To the transpupillary.
How does it kill the cells, tumor cells?
By the high temperature that we're using.
The heat.
It's basically coagulating
and
the
how
cells.
hot is it when you do diode laser thermotherapy?
That somebody should help me out here.
Just a few degrees more than normal body temperature. That's exactly what he's talking about. So what he's trying to tell us is thermotherapy of the ocular surface. Thermotherapy has been in vogue for intraocular tumors, and we've been doing diode TTTs all the time. without real, it's not photocoagulation, mind you, it's just thermotherapy. And he's basically demonstrating the whole technique. So thank you very much, sir. I thought I'll drive home the principles. And the other thing was you're talking about dripping. I wonder, and I have residents who with me, and then we're doing bipolar cautery, not for tumor settings. And I don't know whether all of you know the difference between bipolar cautery and monopolar cautery. So you want to pick somebody in the audience to junior person, say how does a bipolar cautery work, and that will come to the dripping that you're doing.
Yes, I think one of the fellows and residents here who have joined us can.
Yeah, pick somebody. So the next time they won't invite me to Pakistan.
I guess somebody at the back.
Pick a name. Give a name.
Okay. Aap naam di, because I'm new here myself.
So basically, what I'm trying to say is when you do bipolar cautery, you need that arc of conduction between the two tips, right?
Yes.
Here he's using it pure for cooling down tissue, so it doesn't really matter. But if you really want to use bipolar cautery, you use normal saline or distilled water. Anybody? Just show of hands.
So
How many say normal saline?
Saline, yes.
How many say distilled water? So you need electrolytes.
Yes.
So distilled water doesn't work. So people think, it's like water, everything is the same. No, not really, actually, it's distilled water. So I was wondering, I was curious whether, do you care whether it's saline? Here's temperature is the issue. Do you care whether it's saline or distilled water?
Saline.
Okay, saline, okay.
So that's available in that rate. I should have mentioned that, sorry.
Right. And those of you, again, who do retinoblastoma work, there's something called death by irrigation. Who knows what that is?
Why don't you enlighten us there?
Sorry?
Why don't you enlighten us there?
No, I'm going to ask, yes. Death by irrigation. Again, it's related to retinoblastoma work, especially intravitreal chemotherapy. Anybody knows?
You're basically drowning them?
In what? How do you kill cells? So basically, not normal saline, which is physiologic, living, good for living tissues. Distilled water kills tumor cells.
Yes, imbibition or like.
Absolutely right. So when you're doing intravitreal injections or do the occasional AC paracentesis for whatever it is,
Yes.
there might always be some cells floating in the ocular surface,
Yes.
which is one of the predisposition for orbital retinoblastoma systemic spread. So you do death by irrigation by lavaging copiously with distilled water. So these are all simple things that I think that sometimes we take for granted, or sometimes we ritualistic follow things, or sometimes we follow YouTube and they say, oh, they're putting something there, and somebody casually misuses the term saline, distilled
Yes.
water, and so on and so forth. There is science behind everything, and I think that's what I saw. Almost everything that you did. So I only wish I had met you 20 years ago. I would have aged much better than whatever it is. But anyway, compliments. And I saw the thing about congenital NLD obstruction. Whose
Yes.
presentation was that? With
Yes,
viscoelastic. No, that and
Viscoelastic was Dr. Shajil.
where is he?
He's not here at the
Is
moment.
that, is that right? There you go. See, so I was very impressed because you're right. There are patients with congenital NLD obstructions where even with forced irrigation,
Yes.
you actually establish patency. So I was thinking whether instead of just lining with viscoelastic, he takes it one step further, goes down the lacrimal duct in patients with proven congenital NLD obstructions, where you get a true regurgitation. Like hydro dissection we do with cataract surgery. You can do
Absolutely.
hydro or visco dissection. It's basically visco recanalization.
We use that even for the angles in glaucoma as well. So,
Right.
like, why not apply it here?
Yeah.
I also injected after I have done the probing.
Yes, absolutely right.
What that does is that all the debris and everything, it tends to
Accumulate again.
everything, then goes to one side or it's washed out.
Right.
Also, if there are any membranes or any valves which have been broken, they also are pushed to one side
Right.
and then the fibros there.
Right.
Don't come back to them.
So like a tissue spacer.
Excellent results. Excellent results.
It's a tissue spacer actually.
Yes.
And an extrapolation of these are viscoelastics. And viscoelastics are made of what material? Pick somebody again.
Okay, please somebody step up.
Sorry, I'm going to very, very basic stuff. Sorry? Right, okay. And that's what is the cheapest one, or what is usually talked about in say, intracameral hyaluronic acid. And you're right. And what is made of your tissue fillers that we use around the
Same
face?
thing, hyaluronic.
Exactly. Just that one is cross-link and synthetic and whatever it is as well. And where do you get hyaluronic naturally from? Anybody? General knowledge.
Boric acid,
Huh?
cock.
Yeah, come on, sir, you're giving all the answers. You're supposed to be old and retired and not supposed to know anything. He knows everything. Rooster combs of the cock, hyaluronic acid. Your cartilage is there in your skin, whatever it is. But anyway, basically these viscoelastics we can use as tissue spacers. And I use actually viscoelastics even in the upper eyelid. Professor Sahab talked about his innovation, gold implants. There are now platinum plates and there are now platinum links. I actually use viscoelastic in the upper eyelid just as a lid loading technique, and it's a simple outpatient, you don't even any anesthesia procedure. Yes. And technically speaking, hyaluronic acid is what we use. 1 cc is what weight? What is the weight of 1 cc of hyaluronic acid? Or what is the weight of 1 cc of water?
1 gram.
Sir, you're saying everything. No wonder, yeah.
This is the problem. The present generations, they don't take interest in the basics. And that's why they don't improve. If you know basics, you can apply them and have new ideas and new innovations and everything. If you don't know basics, you are just copiers. And this is the problem.
Right.
In our part of the world.
Every part of the world, sir.
We are not talking of the basics. अब देखो सिंपल से सवाल थे, इनको नहीं पता कि 1 ग्राम वाटर या 1 ml वाटर 1 ग्राम होता है. पता भी होगा तो बताते हुए डर रहे हैं, पता नहीं है कि नहीं. So basics are many times they ask me कि आपने लोहे का इम्प्लांट क्यों नहीं रखा आंख में और गोल्ड का क्यों रखा. So then I asked them that what should be the properties of the implant, and they say yes sir, it should be inert. And what else? And then they don't have an idea.
Right.
I tell them it has to be of the minimal volume. As you came to the platinum is more, it has got more specific gravity than gold. Iron is 7, gold is 19, and platinum is 21.
Look at that. Basic school chemistry.
So platinum implant will be still smaller.
Right.
एक इम्प्लांट एक ही साइज का गोल्ड का हो और एक ही साइज का लोहे का हो, तो लोहे वाला जो 1/3 उसका हल्का होगा. ठीक है ना. इसलिए जब गोल्ड इम्प्लांट बनाएंगे तो वो लोहे के इम्प्लांट से 3 गुना बारीक होगा. ठीक है, because it has got more specific gravity and it also has the property of being inert. So basics, this is what I stress. वो कहते हैं कि वो बक रहा हूँ जुनू में क्या क्या कुछ तो समझे खुदा करे कोई.
So maybe I will invoke one of the youngsters. You're doing such wonderful work. Like I said, I am authorized to inject hyaluronic acid in the eyelid because it's tissue fillers. We inject in the face. Maybe I'll challenge one of your students or your teams or multi-center study, Professor Zaid, in facial palsy with lid retraction where you otherwise would do a gold weight. Yes, hyaluronic acid, Helon is available, but Helon is not the same as a commercially available tissue filler. I cannot do the study because of ethics issues in Singapore. Challenge the youngsters to do multi-center study, prospective randomized, into viscoelastic Helon, which is hyaluronic acid but not cross-linked, and non-Helon viscoelastics as upper lid loading technique. 1 cc is 1 gram, he told you. If you need 1.1 gram, you inject 1.1 cc, but you know hyaluronic acid always expands. And present that as a paper next meeting as well. So this you have the luxury to do, and now teach all of us elsewhere where our hands are tied that this is just as good. And once you publish it in an international journal, that becomes evidence and it makes it easier for us to do even better job for our patients. So if you don't mind, sir. Yeah. But anyway, I completely enjoyed it. From the congenital NLD obstructions, the video I saw, he was going through the lower punctum.
Yes, it did.
For probing, you tend to use upper or lower punctum?
No, the lower punctum.
Really? Professor
No,
Sahab?
what did
More straight one, easier one.
Yeah, that's what I was
straight one,
observing.
no?
Yeah.
Lower wala se karte.
Yeah, why do you use the lower? You have to go through a convoluted angle. It's not even 90 degrees. In fact, the lower canalicus goes up. Then you have to turn more than 90 degrees.
More than 90.
And you can actually be kinking the common canalicular end and getting
Over
false
90,
passages and stuff like that. So I was taught somewhere when a younger age, the lower punctum is the patient's punctum, the upper punctum is the surgeon's punctum. Have you heard that before? Yeah. So even my recanalizations that I do, endoluminal duct recanalization, which is a form of an adult probing, I tend to use the upper punctum and upper canalicus. It's more straighter, easier access to the
But I
nasal.
think usually what we do here is the lower punctum that we use. Yeah, but I think that's a better idea, yes.
And but for that, the difference is you all do your procedures with the patient sitting up or slightly reclined, right?
Yes.
So I do this all in my procedure room. You have a beautiful procedure room. So I lie the patient down, adequately topical anesthesia once or twice with proparacaine, 4% pledget. We talked about it the other day. Dilate the punctum well.
Yes.
And actually, you can do an adult probing in the office all the way down with the technique I mentioned the other day, what is called endoluminal anesthesia. Basically, it's nothing but dilute local anesthetic, give a 0.1, 0.2 cc squirt inside in a patient who's obstructed, anesthetizes the entire lumen. Then actually you can do an adult probing. And somebody, you were asking, and the other speaker was also talking about adult probing. It can be done. It is successful 30-40% of the patients. Then you go with intubation, it increases success rate. And my practice, there's a group of patients who have only focal inferior NLD obstructions who actually can benefit from it without needing a DCR. So anyway, these were some of my observations from today's presentations. I completely thoroughly enjoyed every one of the presentations I had, Orbit, Lid, Lacrimal. I learned a lot. I missed the aesthetic because I was sitting in the retinoblastoma session. I enjoyed that and seeing the good work that you all do, and just probably all of you need a big clap. I think that's what you do. And thank you very much for the invitations. So I hope that suffices what you wanted me to say.
हम हमेशा पूछते हैं, would you be coming again?
Yes, sir.
And would you recommend the others to come? और कल हमने किया ना स्क्विंट के ऊपर सेशन, तो उसमें हमारा एंड में वो जो होता है उसमें परफॉर्मर्स में पूछते हैं, वी आस्क क्वेश्चन, तो उसमें वुड यू रिकमेंड दिस कोर्स टू द अदर पीपल? यू ऑलवेज आस्क, सो दैट इज इट. And recommendations you have already given. Thank you. So it was a lively session. Yes, we had different views on different topics. And today the conference is coming to an end. ये conference जो होती है हमारी, this is not only a place to learn, it's also a place to meet each other, come across each other. And just I always tell my juniors that we don't just learn ophthalmology from each other. We learn manners, we learn attitude, we learn attitude towards life, approach towards life. We learn so many things from each other. So never ever, and another thing I always tell them, always be a good listener, but and not a blind listener. Always be a good listener, and always wait whatever the other person has said is practical or not. You can might somebody come from America and tell us something, methods and drugs which are extremely expensive or not available, and we are, oh, what was it? Well, always keep that in mind, but always think of your local conditions. And then and go for the basics, and then try to innovate your own method. And I always tell them, never underestimate yourself. I always tell them, never underestimate yourself. If you start thinking, you'll be surprised what ideas are coming to your mind. You'll be surprised. So never underestimate yourself, and try to go through the basics. And whatever you are doing, you should ask yourself why. Why? ये मैं कर रहा हूँ, जो मेरे उस्ताद करते थे. My teachers used to do that. Why did he do like that? So if I'm not able to understand, I should ask him, sir, why are we doing like that? So always inquisitive, and try to learn from each other. As I told you, we have learned so many things from our juniors. And whenever I go to a conference, I always tell them that I'm not here to teach. I'm here to exchange knowledge. And I always tell them, it might be that you gain more from me because I've got more experience. But I have come to learn. We always learn. So keep your mind open and keep changing. हमारा होता है कि जी, this is my method. I have done it over the past 40 years. I'm not going to change it. No. One has to. You never know. You are doing something for the last so many years, but maybe now you do it the other way around. So, option, keep your mind open. और आप हजरत को सारों को खुदा हाफिज भी, पता नहीं दोबारा इस सेशन में मिलेंगे इकट्ठे या हम कहाँ कहाँ जाएंगे, ठीक है ना, और जाके जो भी कुछ आपने पढ़ा उसको अप्लाई भी करें, हैं. एंड ऑलवेज वट एवर यू आर लिसनिंग, ऑलवेज थिंक इसमें से व्हाट इज practical for me, what can I do out of it, what can I adapt out of it. कल मैं किसको कोई प्रोसीजर वो बता रहे थे तो मैंने कहा दिस इज समथिंग वी कैन ट्राई, ठीक है ना. वो यासिर साहब कह रहे थे छोटा इंसियन, तो मैंने कहा बड़ा सर्जन बड़ा इंसियन, बिग सर्जन बिग इंसियन. बट देन ही showed a procedure and told my person sitting there, we are going to copy it, try it, this is worth trying. So that was just jovial part of it, but the thing is we always learn, ठीक है ना जी. जाहिद आप कुछ कहना चाहेंगे? Parting is sort of a parting talk. इसके बाद हम पता नहीं कौन से सेशन मिलेंगे या अगले साल मिलेंगे.
Or we may see each other in heaven, you don't know. Thank you very much. I'm glad we are all here, and President of the Oculoplastics Association is here as well. And as we discussed earlier, now I think we should also utilize this forum for public awareness. Like we all discussed about how to massage or compress the lacrimal sac. So these small videos we can make, and we can get your opinion as well. And we can also do in the local languages so that more people can benefit from it. And the other thing which oculoplastic needs to do is to involve the other disciplines. Because unless we work on multidisciplinary team, our specialty won't grow. Sometimes we've got a big facial-maxillary team in the hospital and they don't know there is an oculoplastic surgeon. So I always make sure that I have good relation with them. And Sadia is sitting here, and most of the time, once every fortnight, she is with the general plastic surgery team. And Salman Hamza also goes there. And so the plastic surgery, oncology team, and facial-maxillary team, immunologist, and rheumatologist, all are colleagues to be working very close. ENT, of course. And last but not the least is the aesthetic part. It's now our duty to retain that. Otherwise, dermatology specialists, they are very much in, they are very much trained for it, and you listened to them yesterday, and they can do all these procedures, but there are also risks of complication, even blindness. So this is our area, our domain. We should take keen interest in the aesthetic procedures as well, and especially the hyaluronic acids. It's available in the market. Fillers, because these are simpler techniques, and we are more aware of it. So thank you very much. Now there is a closing ceremony in the ballroom.
In the ballroom, yes. Sir.
Ballroom. Abrar sir, before we go to the ballroom, kindly make concluding remarks.
हमारे सदर हैं ओकुलोप्लास्टिक के प्रोफेसर.
Thank you. Thank you very much. So I am glad that our oculoplasty is growing. So it is growing in all the provinces, and the big thing is that they are more and more cooperative with each other, and they are trying to share knowledge, and they are trying to transfer their knowledge to the juniors. This is a very good point in Oculoplastic Society. So I'm very happy that our sessions were very, very successful, and we learned a lot. We were here as students, not as a master, not as a trainer. Everyone of us is students. So we learned a lot, especially from our friends from outside. They have given us new era of the thinking. So we'll think and then we'll apply these things. Thank you very much. So I am very, very thankful to all of you. And here I'll close it.
And Dr. Gangadhara Sundar wants to announce a couple of membership for international associations, sir.
I mean, you have 200 million population, and you have patients coming from Afghanistan and a lot of other places. Singapore, we have 6.5 million population. The point I'm trying to say is you have all the pathology, you have all the experience, you have all the patients. Go beyond, think beyond the country. I think that's what Professor Sahaf is trying to say. Think beyond your borders, think beyond your country. Don't just become members of Pakistan Oculoplastic Association. Then next step will be to become members of Asia Pacific Society of Ophthalmic Plastic Reconstructive Surgery. And I have a passion not for just oculoplastics alone. I was talking to Professor Zaid and trauma. Asia Pacific Ophthalmic Trauma Society. Yes, these memberships are expensive. We deliberately toned down the cost based on the developing whatever status as well. But the incentive for youngsters is the younger you are, and these are life membership societies. I think it's $400 or something like that. You're going to practice 20, 25 years. It's $20 a year. So theoretically speaking, it's affordable. And for of course, the seniors is a little different, but I think it's still worth it. By joining and becoming part of a national, international, supranational organization, your voice is heard. These jugaad techniques will be more visible. People will take note, get greater opportunities to collaborate, publish. So may I invite you all to join AP Sopris. You can go to www.ap. I don't have any conflict of interest. I was just a past vice president. That's about it. And APOTS, which is Asia Pacific Ophthalmic Trauma Society, like we talked about, which is the one specialty which brings cornea, cataract, glaucoma, retina, peds, plastics, neuro-ophthalmology, and allied health workers. We talked about it yesterday, how partially blind or completely blind patients have to be rehabilitated physically, professionally, and psychologically. I invite you both to join AP Sopris and APOTS, and I wanted to mention that. Thank you very much.
Thank you, everybody. Anybody else who wants to make a comment or suggestion before we depart? If not, then let's move to the ballroom. I think there is also, lunch is also served there. So after that, that will be the concluding session. Thank you very much.
वैसे ही लगता है